Hello there. Thank you for attending this presentation on palliative sedation. My name is Amy McCanch. I'm a registered nurse with my certification in hospice palliative care nursing, employed by the University-Muskoka Hospice Palliative Care Network, and I will be your host. Let's get started. So the objectives of this education series is to discuss indications in which palliative sedation is used, explore the ethical principles associated with palliative sedation, examine indications for continuous and intermittent palliative sedation, identify criteria prior to initiating palliative sedation, and review medications used in palliative sedation. So, hospice palliative care is a specialized form of healthcare. Hospice palliative care aims to relieve suffering and improve the quality of life for those living with a life-limiting illness as well as their families. Hospice palliative care addresses the specific physical, psychological, social, spiritual, and practical issues and their associated expectations, needs, hopes, and fears on an individual basis. The benefits of a palliative approach to care include early identification to ensure implementation of pain and symptom management. Good palliative care determines the cause of pain and works with the patient and family towards ways to alleviate it. A palliative approach to care looks at a person holistically and identifies supports, including caregiver support. In the event when symptoms at the end of life become refractory to maximize pharmacological and psychosocial interventions, palliative sedation is a potential option for alleviating suffering at the end of life. So, palliative sedation is defined as the intentional administration of sedation to relieve intractable symptoms or suffering when all other interventions have failed or are not readily available and death is imminent. So, we'll list some indications for when palliative sedation might be appropriate. Number one, intractable, meaning hard to control or hard to manage, agitated delirium. Number two, intractable dyspnea or shortness of breath. Number three, refractory, meaning stubborn or unmanageable seizures. Number four, intractable pain. Number five, psychological or spiritual distress. This raises the question of existential grief as controversial, and Pallium debates this as an indication for palliative sedation therapy. The European Association of Palliative Care Experts Working Group on Palliative Sedation suggests temporary or intermittent palliative sedation in the case of existential or psychological suffering as the indication. Once it is felt that these interventions have taken effect, sedation can be tapered with the goal of being discontinued, referred to as a respite sedation. So, with the implementation of spiritual care and all the other supports that might be needed to address an existential or psychological suffering, you would want to implement those supports to help alleviate that distress. So, what does intractable mean? Intractable symptoms are described as hard to control or deal with, a condition that does not respond readily to medications or treatments. What are refractory symptoms? So, refractory symptoms are symptoms for which all possible treatments have failed, or it is estimated that no other therapies exist within the patient's time frame or tolerable risk to benefit ratio. A patient experiencing refractory symptoms must be differentiated from a patient who has symptoms that are difficult to treat. Refractory symptoms are symptoms that the palliative care physician and team determine cannot safely be relieved by invasive or non-invasive interventions. And we'll go through this a little bit further down in this presentation. So, double effect. Suppose that you know that an action has two consequences or effects, one good and one bad. Is it morally permissible to perform that action? It is often impossible to do good to patients without also causing them some harm because treatments have side effects. It may also be necessary to do something to a patient which would be harmful and wrong outside a medical context. It is done because it will benefit the patient. In the principle of double effect, the primary intent of relieving suffering outweighs the second unintentional effect of shortening life. The double effect doctrine forbids the achievement of good ends by wrong means, but it permits actions with a double effect, both good and bad, under certain conditions. Number one, the act performed is not itself morally evil. Number two, the good effect does not result from the evil effect. Number three, only the good effect is intended. Number four, there is a proportionate reason for causing the harm. So, what to discuss with patients and families when considering initiating palliative sedation therapy? Have a conversation about palliative sedation with the patient and family, and obtain informed consent. Patients will remain on analgesics while sedated. Explain that it is not euthanasia. Discuss hydration and nutrition. With light sedation, patients are able to drink. If the patient has stopped eating, or if the patient is in the last days and hours, artificial hydration will not improve quality of life. Artificial hydration can be started if the life expectancy is more than several days or at the family's request. And that has been taken from Pallium Leap core slide number 20. So here's a slide that compares palliative sedation and MAID. The primary intent of palliative sedation is to alleviate intolerable suffering from distressing symptoms due to progressive incurable etiology, which may be refractory to medication management. The sedation level is determined by the physician based on the comfort of the patient and the outcome of comfort level. Remember that the goal of palliative sedation therapy is to alleviate the refractory or intractable symptoms by least possible sedation. In some cases, a light sedation would alleviate the stress of the intractable symptoms while maintaining the patient's wakefulness, versus medical assistance in dying, which proposes a primary intent to end a patient's life. So the goal of intervention with palliative sedation is the intentional lowering of the patient's level of consciousness to a target level of light versus deep sedation so as to remove the patient's awareness of distressing symptoms, versus MAID to end a patient's life so that the patient no longer has to endure intolerable suffering. The reason for intervention for palliative sedation includes the presence of distressing symptoms due to progressive incurable etiology that is refractory to medication management, versus MAID. All of the following criteria must be met. Number one, patient has a serious incurable illness, disease, or disability. Number two, the patient is in an advanced state of irreversible decline in capability. Number three, the patient's illness, disease, disability, or state of decline causes them to endure physical or psychological suffering that is intolerable to them and cannot be relieved under conditions or with treatment that they consider acceptable. And number four, patient's natural death has become reasonably foreseeable, taking into account all of their medical circumstances. The request for intervention for palliative sedation therapy includes the patient themselves, or alternatively, an alternate decision maker that can make a request for intervention on behalf of the patient who lacks capacity due to confusion, delirium, or loss of cognition, contrasted with MAID, in which requests must be made voluntarily by adult patients with the capacity to provide informed consent. So the Calgary guidelines list the following criteria which must be confirmed before palliative sedation can be initiated. Number one, a terminal disease must be evident. Number two, a refractory symptom must be evident with all possible symptom management explored prior to implementation. Number three, the patient must have a do not resuscitate order in effect. If possible, this patient should be assessed by a palliative care specialist to ensure all symptom management has been assessed. The patient or substitute decision maker, if the patient is incapable or delirious, must give informed consent. Also wanting to stress here that the criteria for palliative sedation therapy and its rationale needs to be documented. Palliative sedation should be monitored by a healthcare professional with expertise in palliative care. So there are two types of palliative sedation therapy. One is intermittent, which is utilized in emergency situations. It's given for short durations. It's administered in subcutaneous injections, which can sometimes be routinely or for a prescribed treatment until symptoms are controlled, versus continuous, which can be administered continuously via subcutaneous infusion and is often used as an alternative when intermittent is no longer effective. So let's look at a couple case studies here. So this is Mrs. Brown. And Mrs. Brown is a 76-year-old woman with a new diagnosis of lung cancer with mets to her spine and pelvis. She has completed her chemo and is now receiving radiation to her spine and pelvic area. Her husband helps her with her ADLs. They have refused all home care assistance. Mrs. Brown denies any pain and is not taking pain medication. During the night, Mr. Brown hears a noise and finds Mrs. Brown laying on the floor. An ambulance is called and she's transferred to hospital. So assessment in hospital shows a spinal fracture to L1 and T12. A stage 3 coccyx ulcer with rolled edges and tunneling is discovered. During wound care, Mrs. Brown is moaning, she's withdrawing, she's swearing at the nurse. CAT scan indicates that Mrs. Brown has extensive mets in the bones and soft tissues. Practitioners deem that there is no further curative treatment available for Mrs. Brown. After discussion with the patient and spouse, a decision is made to transfer Mrs. Brown to a residential hospice. The hospice admitting nurse determines that the patient's palliative performance scale is 30% on arrival. The palliative care physician ordered hydromorphone 1 milligram every 4 hours as needed, PO for pain. Mrs. Brown, she denies pain and declines to take her PO pain medications. She later admits to her nurse that she did not want pain medication because it made her sleepy and she wanted to visit with her family and friends when they came to visit. Orders were changed to hydromorphone 0.5 milligram, 1 milligram sub-Q every 4 hours PRN for pain. This is utilized via a subcutaneous port. After health teaching by the RN, Mrs. Brown agrees to take a subcutaneous injection prior to personal care and dressing changes. So 2 weeks later, Mrs. Brown has been titrated to hydromorphone 2 milligrams sub-Q every 4 hours routinely for pain. Her breakthrough is 1 to 2 milligrams sub-Q per hour as needed. Mrs. Brown often lies in bed moaning but denies any pain. However, if she is moved, she screams and cries in pain. She requests to be left laying on her right side as she is most comfortable in that position. The medical doctor orders a pain pump to be initiated. Her 24-hour total consumption is 24 milligrams hydromorphone sub-Q. The pain pump is initiated at a continuous rate of 1 milligram per hour with a bolus of 1 milligram every 20 minutes PRN. Over the next few days, a CAD pump is titrated to infuse hydromorphone at 1.5 milligrams per hour continuously with a bolus of 1.5 milligrams every 30 minutes PRN. Mrs. Brown begins to show signs of neurotoxicity, and her CAD pump dosing requires an adjustment. Mr. Brown is upset that Mrs. Brown's pain is still not controlled. Mrs. Brown's coccyx wound is now stage 4, encompassing the entire right buttock and some of her back. The first Ativan was given prior to care, which is ineffective. Then a conversation of risks versus benefits is explored to trial a form of palliative sedation, intermittent palliative sedation, which includes Nosenan sub-Q. Nosenan 12.5 milligrams sub-Q every 12 hours was trialed with little effect, unfortunately. Is Mrs. Brown a candidate for palliative sedation? We say yes. She has intractable pain, and all other treatments have been exhausted. So, which palliative sedation therapy is best for Mrs. Brown? So, intermittent versus continuous. So, we would go with intermittent because she doesn't want to be sedated all the time as she wishes to interact with her husband up until she can no longer communicate. She's still eating and drinking. Her pain is only intractable when care is being completed. If she's eating and drinking, Her prognosis is probably greater than 2 weeks, we would say here. This patient was provided with 1 milligram midazolam sub-Q prior, during, and post-cares to maintain sedation while care was being performed. As Mrs. Brown's body developed a tolerance, she was given 2.5 milligram prior, during, and post-care until her demise. Mrs. Brown was cognizant until 24 hours prior to her demise. Consent was obtained by both patient and husband for intermittent palliative sedation therapy while care was being done. By utilizing intermittent palliative sedation, the palliative care team is meeting the goals of care set up by husband and patient to be able to communicate as long as possible. Mrs. Brown maintained her ability to take sips of fluids up until 24 hours prior to dying. Therefore, continuous would not have been appropriate because there was no consent for continuous. She had been eating and drinking. Her prognosis was greater than 2 weeks, and she maintained drinking until 24 hours prior to her death. So this is a little bit of a decision tree for palliative sedation therapy guidelines. This flow diagram was developed by the Champlain region in the Ottawa area, which illustrates the decision-making thought process when deciding if palliative sedation therapy is indicated. So we'd start at the top. Have all treatment options failed to control the symptoms? Yes versus no. Can the treatment options be given without unacceptable side effects? Yes versus no. Is the treatment option available at a setting reasonably accessible to the patient? Yes versus no. Will the treatment option be effective within a reasonable time frame? Yes versus no. If you're hitting any no's along this way, and you have refractory symptoms, you may in fact consider whether or not palliative sedation therapy could be utilized as an option. So this case study is on Andrea, and Andrea is a 47-year-old female who's been diagnosed with metastatic small cell lung cancer just 15 months ago. She has finished her palliative chemotherapy and radiation. She's dependent on oxygen at 4 liters per minute via nasal prongs. She's divorced and has 2 children. She has completed her advanced care planning and designates her best friend, Shayna, to be her power of attorney for personal care. Her care team has worked carefully with her to consider a do not resuscitate order, understanding that her goals of care still include palliative chemotherapy, radiation, perhaps some IV antibiotics, and transfusions. Andrea does not want BiPAP or admission to the ICU for ventilation. And Andrea enters the hospital for an exacerbation of her dyspnea, and she has new edema to her face and arms. After a chest x-ray and CT are completed, she has been informed that she has had further spread of her cancer with development of a superior vena cava syndrome due to tumor invasion to the SVC wall. Her palliative performance scale is 40%. Respiratory therapy is consulted and oxygen therapy is increased to 8 liters per minute via nasal prongs. Dexamethasone 8 milligrams PO/TID and hydromorphone 0.5 milligrams PO/QID is ordered to assist with symptom management of her developing disease. So over the following 2 days, Andrea's respirations become rapid and shallow at 33 respirations per minute. Nursing positions her in high Fowlers to assist with her dyspnea while loosening her clothing and encouraging relaxation techniques. A small fan is positioned to oscillate across her cheek to stimulate the trigeminal nerve, further assisting with symptom management. Unfortunately, little improvement is seen, and the team increases her opioid scheduling from hydromorphone 0.5 milligrams PO/QID to 1 milligram sub-Q, Q4 hours PRN. Some relief is noted with an increase of her opioids, but her dyspnea ESAS rating remains a 6 out of 10. Andrea is becoming tired and discouraged. Ativan is provided to alleviate symptoms of anxiety. BiPAP and admission into ICU go against Andrea's goals of care. When symptoms continue to excel, Andrea is placed on a hydromorph CAD pump at 0.2 milligrams per hour with a breakthrough dose of 0.25 milligrams every 30 minutes after her dyspnea escalates 2 days later. So Andrea's respirations are now 25 a minute, and she's utilizing all accessory muscles to breathe. She's grimacing, she's moaning. Tears are visible, indicating refractory symptoms. She is no longer eating and can only manage sips of fluid. The palliative care team is consulted Andrea is capable and she's able to consent to some added sedation to alleviate her dyspnea, despite knowing that sedation may make her more sleepy and lethargic. She reports an ESAS dyspnea rating of 8 out of 10, which is not acceptable for her. Methotrexate, or Nozanan, 12.5 milligrams sub-Q BID is added to her medication regime and provides some effect, but does not provide enough symptom management to alleviate her grunting and labored breathing. So methotrexate is one of the many medications used for intermittent palliative sedation therapy. Andrea becomes sleepy, restless, and disoriented. Andrea's daughters are distraught. The palliative care team pulls upon Shayna as a power of attorney personal care to explore if a continuous infusion of midazolam can be considered. What would you do next? Let's review this case. So here's a dyspnea management algorithm, and we can kind of just go through the steps here. We've done her dyspnea screen, we've done her assessment, identified and treated any reversible causes, treat hypoxemia with supplemental O2. She's on oxygen. We've consulted RT. We're trying to treat her symptoms of dyspnea, implementing comfort measures. We've implemented the fan to stimulate her trigeminal nerve. We've positioned her in high Fowlers. We've loosened her clothing. We've looked at some relaxation techniques. We've initiated some opioids as per gold standard treatment for dyspnea. We've initiated Decadron to relieve inflammation of her tumor burden. And unfortunately, she still has refractory symptoms. Sub-Q BID Nozanan is ineffective. She still has refractory symptoms. So we will certainly consider her for midazolam at this point. So Andrea is exhibiting only minimal intake, suggesting to her palliative physician that Andrea's disease has progressed and she now has a guarded prognosis with an anticipated prognosis of hours to days. Shayna and the family determined that Andrea would be more comfortable with a continuous infusion of midazolam initiated at 0.5 milligrams per hour and request a moderate sedation. Palliative sedation therapy does not hasten nor prolong dying when used ethically and legally. Continuous palliative sedation therapy should only be considered when death is anticipated within 2 weeks or less. The nurse uses a RAS-PAL score of -3, moderate sedation, to guide therapy titration. Andrea will have some slight body movement and possible eye opening in response to voice stimulation. The family sit at her bedside while whispering wishes and tributes quietly. The team carefully titrates Andrea's midazolam infusion to achieve the desired therapy, and Andrea passes in hospital peacefully within 3 days' time. So, a terminal disease must be evident, as suggested by hours to days. A refractory symptom must be evident, with all possible symptom management explored prior to implementation. The patient must have a DNR order in effect. If possible, the patient should be assessed by a palliative care specialist to ensure all symptom management has been assessed. And the patient or a substitute decision maker, if the patient is incapable or delirious, must give informed consent. So, medications that we might use for palliative sedation therapy. I guess the goal is to achieve the lowest possible dose and lightest level of sedation that achieves comfort. I cannot stress enough, opioids are not to be used for palliative sedation therapy. They are ineffective for this purpose and associated with a higher risk of neurotoxicity if titrated rapidly. However, it is essential to continue to provide opioid therapy for symptom management if a patient is already on them. The goal is to identify the lowest possible dose of medication and lightest level of sedation that achieves comfort. In some cases, comfort may be achieved with light to moderate sedation, while others will require deeper levels of sedation. The most common medications used for palliative sedation therapy are midazolam, methotrexate or Nozanan, and phenobarbital. Choices depend on the clinical circumstances, the experience of the physician, drug availability, institutional policy, and location. So, when we look at methotrexate or Nozanan, we're going to start with 2.5 milligrams to 5 milligrams PO or sub-Q every 1 hour PRN. If PRN dosing is insufficient to maintain control, add 2.5 milligrams to 5 milligrams PO or sub-Q OD or BID. The onset of action is 10 to 15 minutes sub-Q and 45 minutes PO. Plasma half-life is 15 to 30 hours and action is 12 to 24 hours. Caution when dosing more often than 6 to 8 hours. Midazolam or Versed is the drug of choice because of the shorter half-life, potency, and it's easy to titrate. If emergent, a bolus of 2.5 milligrams to 5 milligrams sub-Q or IV is provided. For continuous infusion, initial dose is 0.5 milligrams an hour or 1 milligram per hour sub-Q or IV. Pallium Canada suggests that dose titration to desired effect should be increased incrementally, 0.5 milligrams to 1 milligram per hour every 20 to 30 minutes as required until the desired clinical effect is achieved. Doses of 1 to 5 milligrams an hour are usually effective. Once the clinical effect is reached, maintain the dose and reassess ongoingly. Titrations up or down, depending on the clinical situation, may be required. Try maintaining comfort at the lowest level of sedation and the lowest dose possible. If the level of sedation is deeper than required, decrease the dose gradually in increments of 1 to 2 milligrams an hour until the lowest effective dose is found. If the level of sedation is excessive and the patient appears to have respiratory depression or respirations less than 8 per minute, halt the infusion and then monitor. Restart the sedation once the respiratory rate has improved. So, second-line pharmacological agents are listed here. If midazolam doses are higher than 10 milligrams per hour, add phenobarbital to midazolam infusion. Add phenobarb 30 to 120 milligrams sub-Q or IV, BID or TID. However, the half-life of phenobarbital is very long. It's actually up to 100 hours. This makes it difficult to titrate rapidly, and several days need to pass to achieve the steady state before the full impact of a specific dosing regimen can be adequately assessed. It may be best to work closely with an experienced pharmacist. Lorazepam sub-Q or IV is not as potent as midazolam for sedation and anti-seizure effect. It could be used as an option if there's a midazolam shortage, and we're conscious of complications that we might encounter with COVID-19 pandemic. Start with 1 milligram to 4 milligrams sub-Q IV every 4 to 6 hours or via infusion 0.5 milligram to 1 milligram per hour to 4 milligrams per hour sub-Q or IV. Propofol is rarely used for palliative sedation therapy and is usually deemed second and even third line agents used when optimal doses of methotrexate and midazolam have failed. Opioids are not considered for palliative sedation therapy. They are not sedatives. So, cannot stress that enough. So, monitoring. Patients should be monitored for level of sedation, level of comfort, and airway patency. The depth of sedation should be assessed using the Richmond Agitation Sedation Scale, or the RASS, or the Riker Sedation Agitation Scale. Because these patients cannot communicate anymore, caregivers have to rely on the observation to assess the patient's comfort. Patients should be monitored for level of sedation, level of comfort, and airway patency. Monitoring every 4 hours in an acute care setting for stable therapy, or every 8 to 12 hours in the home, residential, or long-term care facility is recommended as per McMaster Palliative Sedation Guidelines. So here's a slide on the Richmond Agitation Sedation Scale, and you're going to observe your patient for at least 20 seconds. If the patient is alert, restless, or agitated for more than 10 seconds, you will score a 0. Can note, if the patient is alert, restless, or agitated for less than 10 seconds and is otherwise drowsy, Then score the patient according to your assessment for the majority of your observation period. If not alert, greet the patient by verbal stimulation. Call by name and say, "Open your eyes and look at me." Score -1 if the patient awakens with sustained eye opening and eye contact, so 10 seconds or longer. Score them a -2 if the patient awakens with eye opening eye contact but not sustained, so eye contact less than 10 seconds, they would be a -2. Score -3 if the patient has any eye or body movement in response to voice but no eye contact. And when there is no response to verbal stimulation, you're going to physically stimulate the patient by light touch. Example, gently shaking the shoulder. Score -4 if the patient has any eye or body movement to gentle physical stimulation, and score them a -5 if you have zero response to any stimulation. Here's another scale that you might see used when implementing palliative sedation therapy, and it's the Riker Sedation Agitation Scale. So dangerous agitation would be scored a 7 versus unarousable as a score of 1. So considerations for stat sedation, and you might see this in any setting. As an example, palliative emergencies in the community. Although uncommon, palliative emergencies can be distressing to patients, families, and caregivers. So an example would be like an ulcerating mass in the neck in close proximity to an artery, a recurrent rectal or upper GI bleed, underlying anticoagulation problems such as a thrombocytopenia. Consider having a pre-drawn syringe of midazolam, 5 milligrams to 10 milligrams, depending on your patient body size, sub-Q PRN for critical events, including hemorrhage, grand mal seizures lasting longer than 2 minutes. Have the syringe at hand and instruct the caregivers on how to administer midazolam subcutaneously in case of a massive bleed. It should be noted that administration via IM route has a faster effect, although if it's in a caregiver setting, they may not be comfortable doing an IM injection. So subcutaneous injections are easier to teach. Administer 5 milligrams stat, followed by another 5 milligrams 10 minutes later if the patient is still not sedated and bleeding or seizures continue. And this has been taken from Pallium Canada as well, 2018, section 14-7. Alternatively, have dark towels on hand if possible. Instruct family caregivers to apply pressure over a bleeding site. Turn client on the left side if there's hemoptysis so as not to suffocate. Can be a pretty scary situation. So some take-home points. In case of untreatable suffering at the end of life, palliative sedation may be chosen to assure comfort by reducing the patient's level of consciousness. The aim of palliative sedation is to give optimal comfort but not to hasten death. The guidelines state that sedation should be no deeper than necessary to avoid suffering. Palliative sedation can be both a welcoming and distressing for patients and their families. Give reassurance that other treatment options did not help. Provide support that palliative sedation will not shorten the patient's life, and provide education as to what to expect. There are 2 types of palliative sedation: your intermittent and your continuous. So we cannot change the outcome, but we can affect the journey. I want to thank you for this. I will just quickly run you through these references so you can see what we've included in the creation of this PowerPoint, and a notation that palliative sedation is not euthanasia. The definition of euthanasia means to knowingly perform an act that is explicitly intended to end another person's life, and that includes the following elements. The subject has a terminal illness, the agent knows about the person's condition and commits the act with the intention of ending that person, and the act is undertaken with the intention to kill, although the motive is mercy. Palliative sedation used ethically and legally does not hasten death. It is a means to improve suffering when there are refractory symptoms. So I hope you have found this informative. And certainly, if you have any questions, feel free to link with the North Simcoe Muskoka Hospice Palliative Care Network. You can find us at www.nsmhpcn.ca for more learning materials. And alternatively, you can contact us at 705-325-0505. Anyways, thank you for making it this far along in the presentation. Take care and have a great day. Goodbye.